And for our second speaker today, it's my pleasure to introduce Barbara Van Hare, who is president of Pattern.org, the Rare Cancer Foundation's online platform, which empowers patients to contribute tissues and data to research regardless of US treatment location. She currently leads all of the team's patient advocacy and institutional relationships, as well as manages Pattern.org's tissue collection. Barbara's presentation is titled From Consent to Collaboration, Practical Insights into Patient Tissue Procurement.
Thank you very much, and thank you, iXCells, for inviting me to be here today. And I am the president of Pattern.org, and Pattern.org is an initiative of the Rare Cancer Research Foundation. And the Rare Cancer Research Foundation was started in 2013 by a rare cancer patient who happened to be diagnosed with ocular melanoma, who was discouraged after his diagnosis to find that basically no treatments had changed in the previous 25 years before he got his diagnosis. And as he did some research and worked with other rare cancer groups, found out his situation was the norm, that very few of the rare cancer groups had had significant change in their diseases in terms of treatments for 20 to 25 years. So he created RCRF in order to build the infrastructure that could be used by any of those rare cancer groups and now also rare disease groups to help get rid of some of the roadblocks that might be stopping research from moving faster. And just for full disclosure, this rare cancer patient happened to be my nephew, Mark Labs. Pattern.org was created in late 2016. We did a lot of research with the different groups, the different rare cancer advocacy groups on what really were the challenges. We talked to a lot of researchers, what were their challenges? And the number one thing they came back and said is, we don't have access to patients and we don't have access to patient tissues. So we created Pattern to provide that infrastructure to be able to work with patients. Currently, it's across the US. It will probably be into Canada within the next year or so, but we are primarily US based now. So wherever they're being treated or wherever they're getting their care in the US, to be able to get tissues from them. For rare cancers, usually it's solid tumor tissue. For blood cancers, of course, it's blood, but we're able to collect virtually any type of patient tissue. And so how does Pattern.org work? Patients learn about research studies for their particular disease. They then go to Pattern. They are then matched to studies. In fact, Pattern is in the process of being updated and should be available, hopefully the new version within the next 6 weeks, where if there's more than one study that a patient can contribute to, they can actually rank their choices of how they would like their tissue to be utilized. It's not guaranteed that necessarily they'll get their first choice. Let's say if there's not enough tissue or there's something about their condition that doesn't allow them, but we will let them know where their tissue actually went. So they're matched to studies, and then they can go through Pattern.org online and consent to that study. If they have questions as they're going through that, they can reach out to us, or there's also a chat feature. Once they consent, we're notified literally within about a minute of that consent process. And depending on the disease that we're working with, whether we need to, if they're having a surgery, let's say it's a rare cancer, then we'll reach out to their clinical team at whatever hospital they're being treated at. It can be a large academic center, can be a regional hospital, it can be a community center. So we reach out to that patient's clinical care team and work through all of the challenges that many of you may know about trying to get tissues out of institutions to get them to release that tissue. The patient can talk to their clinician about wanting to participate in the study, not required. If they don't feel comfortable doing that, we're happy to take on that burden to get that tissue out for them. So then we coordinate the transfer of their tissue and data because we'll also get the clinical records associated with that patient's case. So some folks are confused, like what exactly does Pattern do and what do the researchers we work with do? So on the left side is Pattern. We handle the patient consent and the tissue donation. As I mentioned, we work with that clinical team to collect the tumor. And in case of rare cancers, we also get the germline tissue. If it's not a cancer, let's say it's a rare disease and we need whatever we need to collect for that, we will work through the details with the group that we're working with to determine what exactly we need to put in the collection kit and who we need to work through to get that. And then we handle the consent and also the clinical data associated with that particular patient. We have the full medical record, but we give de-identified information to the research groups that we're working with. Then over on the partner researcher side, they are the ones that develop the models and any genomic or other data. We get the tissue to them. If it's fresh living tissue from like a solid tumor, then we have it overnighted the day of the surgery. So it arrives by 10:30 the next morning. The only hiccups we have usually if there is a FedEx delay, like due to a snowstorm or something like that, but we will track it. We will let the research group know where it is along the way and when it arrives. And then the researchers we work with, we really, again, we were founded to help break down those roadblocks that were preventing progress. So we strongly encourage and in many cases require that the research groups we're working with share the data pre-publication. For biotechs, we make some exceptions, but we'll work with them on what data they might be willing to share. And then that data that is shared would go through public biorepositories. Also, any models that are generated, again, with biotechs, it may be slightly different. We require that those models go into like an ATCC or other biorepository. How do patients find out about us? We have a wonderful network of foundation partners. This is just a small list of the ones that we work with. We will work with actual foundations. We'll work with social media groups. And we're also in the process of working, setting up agreements with some smaller community hospitals where actually tissue from many of the procedures literally gets thrown away. And so we're working to try to set up a more effective system to utilize those tissues. Who are the research partners we're working with? The ones listed here are the ones that are currently on our website that patients can consent to, but there are 11 additional sites that we are currently in the process of onboarding. From the work that we've done, again, primarily it's been rare cancers, but we can help rare disease. 65 research models have been created and they are available and in the public domain or shortly to be in the public domain. We have collected from over 120, well, it's 120, I think the last count is 124 hospitals. And again, I should stress that the primary work that we have done to date has been with fresh living tissue, not with stored tissue, but we're also capable of collecting stored tissue. We've collected from 39 different states and 20% of our samples have come from underrepresented groups. So kind of an overview of what we're doing with Pattern and with RCRF. Patients contribute to research and empower themselves at the same time. We get those tissue donations. Historically, what we have done is we collect the tissue, whether it's a blood draw, whether it's tumor tissue, whether it's normal tissue, and then we send it directly to the research lab. We have recently been working with some groups that have asked if we could store tissue for them. Let's say they need 10 or 15 or 50 samples of a particular tumor or biological material. We now do have a biobank in conjunction with Precision for Medicine so that we can store the tissues there. We can also do different assays there. And so we'll work with the groups that want to work with us on, do they want the tissues direct or to go through the biobank? We collect the medical records. We're also encouraging, particularly for cancer patients, but for others that where it might be interested, is to get genomic sequencing. And so we're more than willing to help communicate to the doctors and try to encourage them to order the genomic test. Several of the companies that do sequencing already have committed that they're willing to share that data back with us. And so we also are in the process of creating a data commons primarily for rare cancers, where that data and clinical data can be stored, but also will be tied to any tissues, any models that are out there, to give kind of a fuller representation for patients and for research. Something that will be starting at the end of next month is custodial biobanking. So if a patient wants to store some of their own tissue, again, particularly in rare cancers, sometimes it's challenging to get tissue out of a hospital, even though a patient may need it for clinical care at another institution. So there will be a charge where the patients will cover our cost on that, but we will have custodial biobanking. On the right-hand side are things that our work is helping to create is models through working with various research partners, the data sets. We do have part of the organization that is also helping precision medicine for particular patients, and there'll be more information about that forthcoming in the next few months. It's been a program that we've been working on for 2 years. Quite frankly, the initial patients that did that, where we basically helped get them personalized vaccines and some other kind of one-of-a-kind therapies, was for fairly wealthy people that could afford it. We now have found a way that we can bring the price down significantly to help those patients. We'll also be doing that. And again, all of this hopefully helps make pathways to cures. And then the learnings and data that we collect will be in open source data commons. So some of the things, whether you work through us or you work with an academic institution or you work with another group in terms of getting patient tissues, there are a variety of considerations that need to be made. Key are regulatory ones, and anything that's doing with human research studies must comply with the regulations and ensure the rights and welfare of participants. So all of these studies require an institutional review board review and approval. And in most cases, that means they need to review the protocol. There needs to be an informed consent. Recruiting materials that are used to recruit patients have to be approved, and security measures to protect any of the patient identifiable information needs to be reviewed. And you can utilize, like most hospitals, academic institutions have their own IRBs. And when we created Pattern back in late 2016, we used Dana-Farber because we were shipping samples to the Broad Institute in Cambridge. And Dana-Farber is an excellent IRB, but we couldn't change one word on a social media post without going back through them, like literally one word. If we had changed a word and not gotten their approval, technically it was a violation. So we worked with the Dana-Farber IRB for the first maybe 2 years. And then as we started expanding our reach and working with a lot of other research partners, it just got too cumbersome to try to keep track of every different IRB. So we, for our work, have switched to an independent IRB. There are a number of them. We are currently working with WCG IRB. And so we have a protocol and a consent that allows us to ship the samples to any of our research partners. We just sign them up initially with the IRB under our protocol, and then it just streamlines the process. Whenever we want to make changes to materials, whenever we want to change the website pattern.org, we're able to do that in a streamlined way. And we're also getting much smarter about the language we use, so that now every time we add a partner, we don't have to go back through the IRB to get them to approve that. Every time we change a word, we don't need for them to review that. Also, if you weren't aware, there are different approval processes for the US and Canada, like WCG IRB. You can get a US protocol and you can get a Canadian protocol, but they're two separate groups and two separate costs for that. And then if there are any protocol violations or incidents, those have to be reported back to the IRB. You have to follow federal, state, and international policies and guidance. Currently, we're not working internationally, so federal and state, but trust me, those can change. And so you need to work with an IRB that is familiar with these things. Like one area, particularly if you have pediatric patients, is the age of consent is different in different states. So you have to make sure that you're covered in the state where that person is consenting. What we do to try to make that easier is we follow one process. We make sure that anybody under the age of 21, that besides the consent online, we also verbally talk to the guardian. Usually it's a parent. It is critical if you are getting patient tissues that the legal guardian has agreed to it, particularly if the parents may not be married. There have been times, in fact, our PI for the pattern study he's a pediatric oncologist. And if you don't get the legal guardian and the other parent isn't happy with the tissue being donated, it can cause quite a liability. So you need to make sure that there's a legal guardian, and then depending on the ages, if the child's of a certain age, you need their assent. Basically, if they're old enough to understand at least a little bit about what you're doing, they also have to sign an assent. And if research is supported by basically any federal funds, at least currently, that follow the common rule, which is basically rules that were created, I think it was in 2017 or 18, to protect patients. You must have an active SAM registration, and you must have a federal-wide assurance. Whoever you're working with that is collecting the samples, just make sure that they have that if they are getting federal funds. If they're not, then basically any tissues that were collected when they didn't have that, there could be a problem with researchers using them. Electronic signatures have different regulations that need to be followed. There may be tissue and data use agreements that need to be signed. If you're planning on exporting any of the tissues overseas, there may be laws for that. And then, of course, with AI coming on the scene, there may be special regulations for that. In terms of consent language, so the actual document that patients or their parents sign, it's really key to put into those documents cost and benefits. So if there's any cost, we don't charge patients unless they want to store their own tissue in the biobank. So you specify if their cost or if they're getting paid to donate any tissues. But it's also important that if there isn't any cost or participation payments, that's put there in there as well. So just be very clear that in a consent that the patient or their family knows. Also, risks to patients need to be clearly spelled out. Even just collecting blood, there can be bruising, whatever, that needs to be in there. They need to know that there is the potential for a breach of protected personal information. Hopefully that is not going to happen, but we have been advised by the various IRBs that we work with that is very critical. And then genomic testing, if that is being done, and if it's being done in a CLIA lab, will any of those results be returned to the patients? In certain cases, they may not be, and that's fine, but that needs to be spelled out. Also, if you are returning that or a group you're working with is returning that, there could be major implications to that family, as most of you in the room know. And so just be aware of that. Vulnerable groups such as pregnant women, prisoners, or those with diminished intellect. We at pattern.org, particularly for rare diseases, rare cancers, we are able to collect from those populations, but a number of studies may not want to collect from those populations. And there also may be language barriers if our consent currently is only in English. Our website is only in English. So if it's a Spanish speaking only patient, probably we shouldn't have them consent because we're not sure that they fully understand what they're consenting to. Tissue types, ensure that the consent gives the capability for whoever's collecting that tissue to collect whatever type of samples you need. And also look forward in terms of what you're planning to do with the tissue, not just today, but what may be your future needs. Because if you have a patient consent today, and let's say in 2 years, you find that you still have some of that sample and there's something else you want to do with it that you didn't think about, you may not be able to do whatever that new work is. So try to think ahead if you can in terms of what might be coming down the pike, and using language that is broad will protect you the most, so that you can be specific, but you should also have expansive language for things that you may not know about today. Think about commercialization. And if you're planning to commercialize, which I think a lot of people in this room would be, make sure that that is in the consent. And then who has intellectual property rights? We at RCRF, we aren't involved with intellectual property rights, but that is a point that can be kind of sticky with a lot of groups. Look at, as I mentioned, current and potential future research and assays that you might want to do. And really key, because we learned the hard way with our initial consent and protocol, we didn't have in there that we could recontact the patients. It's really critical, we think, with rare cancer, rare disease patients, that there's the opportunity, if a patient wants to opt into this, that you can contact them in the future for additional studies that may come down the pike, either at your company or another company, and also for contacting them to make sure that their contact information is up to date, and that there is a backup contact. Again, with rare cancer patients, some of them may not be alive in a year or two, and so you need a backup contact if you have some of that tissue remaining, or there's a finding that has come out of the research. If you and your company or your foundation have decided that you want to be able to give that information back to patients, and it's, again, fine if you want to, fine if you don't, but make that decision before the patient's consenting. And as I mentioned, for research-only results, historically, you haven't been able to give those back to patients. There have been some situations where now you can. So make that decision up front if that's something you want to be able to give back to the participant. Logistical considerations for tissue collection, since we collect literally from anywhere in the US, including Alaska and Hawaii. We are technically not a covered entity, but we still follow HIPAA because we feel that's what we need to do to help protect the patients. We assign participant and case identifier codes so that the researcher receiving the tissue doesn't know who the patient is. We are starting to use GUID coding, which is a special participant code. One of the challenges with those are there are various companies that do that. That helps track what studies a participant is participating in, but with different companies using different codes, it's a little tricky. And so we're going through all the learning process of that now. And then some studies, particularly some that have gone with NIH, there was a Human Cancer Model Initiative program that we were a part of a few years ago. Models that were created from samples that we sent to the Broad Institute that are now at ATCC. We aren't able to tell which came from our samples because they mandated that information was delinked. Sample transfer requirements, depending on what type of samples you want, make sure you're clear as to how you want them sent, whether they're frozen, ambient, refrigerated degrees. Make sure you're clear with who's ever sending those. Saturday deliveries are kind of a big thing in our world because there are a lot of surgeries that occur on Fridays, and most labs aren't open on Saturday. So you have to make sure what's going to happen with those Saturday deliveries. Contamination risk reductions. There are some labs that don't want to deal with certain diseases because of potential contamination. So just be aware of that. Post-mortem collections, we get asked about this a lot. They're doable, but they are very challenging, particularly if we're looking at solid tumors. And home collections, where blood draws are usually done. Really the only risk that we have there is if whoever is doing that blood draw does not cover up the label as we instruct. and leave if the kit went directly to that patient's home and their name and address is on there, that's not good if it gets to the research lab because that's technically a violation. So you just have to make sure you cover those bases to make sure you try to reduce the chance of that. And then if required, sign material transfer agreements and use agreements. The way we get tissue to various research projects is through the use of a fairly basic material transfer agreement. And that's it on Pattern. We really, just like Irene said, we put patients at the center of everything we do. And we appreciate your time listening today.